Hello, everyone, and welcome to this Ask the Experts webinar. My name is Shannon Lozinski, and I'm the Director of Patient Services at the Chordoma Foundation. Thank you all for being with us today. I'm really glad to have you here. As many of you know, the Ask the Experts panel is a foundational part of our yearly Chordoma Community Conferences and is always one of the most valuable and appreciated sessions. The community conference plan for this summer was postponed until next summer due to the pandemic, but it was important to us to still provide you with this opportunity to get your questions answered. So we're very happy to bring you this Ask the Experts panel as a webinar. And huge thanks to the doctors joining us today so that this webinar is possible. Before we get started, I will quickly go through a few reminders and housekeeping notes, and then we'll jump into the Q&A. We have 90 minutes for this webinar, and we will do our best to make sure we get through all your questions. If for some reason we can't get to all the questions, our Chordoma Foundation patient navigator, Andrea Locke, and myself will follow up with those of you whose questions did not get answered. In order to make the best use of our time, similar questions will be grouped together as much as possible. And please keep in mind that the answers given by the experts today are for informational purposes only. The doctors cannot give medical advice in this setting, and they cannot address your specific situation since they do not know your case. And it's always best to discuss any information presented here with your care team because they know your case the best. And just a note that this webinar is being recorded, and it will be available on our website and on our YouTube channel next week. So if you or want to go back and listen again, you can use that recording to do so. The tool that we'll be using today to submit questions is the Q&A tool, which you can access at the bottom of your screen. You click that icon and a box will pop up. Type your question in that box there, and then our moderator will questions to the panelists. And I see actually that we have a question already, which is great. And you can, please note that you are able to submit questions anonymously. There's a small checkbox below where you type in your question, and you can select that option you prefer. You can use the chat feature to send messages to other participants, but please don't use this box to submit questions for the panelists to be able to monitor it as closely as the Q&A box. And if you have any technical issues during the webinar, please send a chat message to all panelists, and someone will help you with whatever you're experiencing. So further ado, I'd like to introduce our moderator for today's session. Dr. Ed Less is a Clavicle Chordoma survivor who's been part of the Chordoma Foundation really since its founding. He's currently a member of our board of directors. He's the chair of our patient services committee and a member of our community advisory board. And when Ed isn't doing all these foundation related things, he somehow finds time to be a pediatric emergency medicine physician, run a virtual pediatric urgent care service, write a blog, and have a family. So we're very glad to have him with us today. Ed has moderated a few Ask the Expert sessions in the past, and we're very grateful to him for being with us again today. Ed, it's all yours.
Thank you, Shannon. That's quite the intro. You made it sound as if I do a lot of heavy lifting, and I have to say most of the heavy lifting that occurs in my family is done by my wife, as I'm sure many of the people on my panel can attest to the same reality in your families. So thank you for inviting me to moderate this panel once again. Obviously, the first time that we've done this virtually because of this pandemic that is upending many of our lives. On the positive side, though, doing this virtually is allowing many people to attend this Ask the Experts panel that otherwise would not be able to attend. And so we find the same thing in my business of emergency medicine with rounds and so on. We're now able to attend rounds around the world. So there's been a silver lining to the fact that we're forced to do some of these things virtually. The same thing applies to the Chordoma Research Workshop, which was conducted recently virtually. We had attendees from around the world that ordinarily would not have been able to come in person. So without further ado, Shannon laid out the ground rules. I'd like to open by just briefly introducing our panel. I'm not going to spend much time on their credentials because we have 90 minutes. That would take, I think, roughly a day or two to go through all of their accomplishments and various credentials. So just to say briefly, we have Dr. Greg Cote, medical oncologist based out of Massachusetts General, Dr. Vinay Gandhi, radiation oncologist based out of Northwestern near Chicago, Dr. Peter Nielsen, a pathologist at Mass General, Dr. Shan Reza, a neurosurgeon, skull-based neurosurgeon, University of Texas at MD Anderson, and then last but not least, Dr. Joe Schwab, who is an orthopedic spine surgeon, also based out of Massachusetts General Hospital. So I'd like to offer a huge thank you to all of the attendees for offering up their time to take part in this very valuable exercise. I know that you're all busy. I also know that it's summertime. Some of you are doing this around some of your free time, vacation time, and so on. From the bottom of all of our hearts, I think, thank you so much for making the time to do this today. And I'd like to say to all of the attendees today, feel free to populate the question and answer box with questions. The old adage that there is no stupid questions absolutely holds true here as well. Don't feel free to ask whatever, and we will do our level best to get to as many questions as we can in the 90 minutes that we have. So I thought a good way to start off with this, we had a great question submitted yesterday, which is a nice way to open our session today. And the question is, what do each of you see as hopeful in the future of chordoma treatment? And I thought I'd ask you, Dr. Cote, if you could open with a response to that question. And the rest of you feel free to weigh in as well.
Sure, great. So first off, thank you again for the invitation to come back to the workshop. It was a great experience last time, and I'm happy to join it virtually this year. So for me, to answer that question, it's really about where we've been and where we're going. So when I started taking care of chordoma patients, which is about 8 or 9 years ago, we had 1 or 2 models that were not that great for the labs. We had a really poor understanding of the biology of what drives chordoma, and we had just a handful of clinical trials. And after our recent workshop and seeing all the presentations, it's really clear how dedicated this community is at really trying to understand the biology of why chordoma happens and how we can find new treatments. And the advances are really incredible. We have a dozen or so mouse models and a number of different science labs working on trying to figure out sort of the basic biology that drives this. And we heard some early talks about some drug discovery approaches, and I find that incredibly exciting. And I feel like we're just on the cusp of a breakthrough now. We were just chatting before the seminar started, and we have around 8 clinical trials now that are dedicated to chordoma patients, which is really remarkable for such a rare disease to be able to design those. So I'm really hopeful that one of these trials will be important for the management of chordoma patients, but I'm even more hopeful that sort of the next step, that the thing that's coming beyond that is going to be a breakthrough. And I'm hoping in the next 5 to 10 years, we're going to see some real presses forward in how we treat this disease.
Ed, if I could weigh in, I concur with the hopeful message that Greg has expressed. I think one of the things that is clear to me is that the multimodal management of chordoma is only going to increase. And what I mean is that there are lots of studies that are looking at how to make the tumor more sensitive to radiation. And ultimately, my hope would be that we can do less and less ablative surgical operations, which is ironic in a way because it affects me, it puts me out of business in some ways. But I think if we can do less and less aggressive surgery combined with adjuvant therapies, radiation therapy or chemotherapy, someday maybe surgery is not needed or it's considered the adjuvant. So I think that's probably the reality. At least I hope it is the reality.
Ed, if I can follow on Dr. Schwab, first of all, thank you to the Chordoma Foundation for inviting me to speak in this webinar, and kudos to the leadership for their ability to pivot and during this pandemic and do these virtually. It's really impressive. We had a great chordoma workshop a couple weeks ago, and this is such a great event. Yeah, I too am very optimistic about where we're moving forward. So one of the basic principles of radiotherapy that I'm going to talk about several times, hopefully today, is that this tumor is unique in the sense that it requires escalated doses of radiotherapy. But the challenge is the tumor also originates around some high-priced real estate in the human body. And so the ability to leverage that therapeutic window is the challenge that we always face. Our technology in radiotherapy are continuing to advance. Our ability to deliver things like radiosurgery or SBRT, terms I'll come back to later, or specifically proton therapy to try to sharpen the edge and escalate dose further, gives us more hope that we are able to deliver the requisite escalated radiotherapy dose that's required for this tumor. But to Dr. Schwab and Dr. Coates' perspective, very much so, the capacity to harness drugs to sensitize tumors to the effects of radiotherapy has so much potential, and we're just starting to see the beginnings of what that might turn out to be. So my optimism for the future is not just our ability to advance those technologies, but under the leadership of the Chordoma Foundation, our capacity to collaborate so well over the last decade plus, and bring our minds together and think about progress moving forward. Ultimately, our hope is that we can bring clinical trials not just to the recurrent setting, but to the newly diagnosed setting, and to do so in a way that stretches all across the country in multiple different institutions. So that's where we're kind of trying to head towards.
If I could just say one thing, I'm just the pathologist, so I don't treat patients. I just tell the other ones what the diagnosis is. But from my perspective, I think the most important thing with regard to treatment of chordoma, and that's why the Chordoma Foundation is important, is that you have to treat it correctly from the beginning. And that's why all the patients that have chordoma should go to centers or places that are used to treating chordomas, because once you mess up the treatment in the beginning, it's usually a downhill battle after that. So the first initial treatment is the most important, whatever you do, combination of radiation, surgery, etc.
I'm going to echo some of those comments earlier also in terms of, why we should be optimistic about the future. First of all, we've seen so much tremendous advancement with regards to our understanding the biology of this disease. And I think to Dr. Schwab's comments earlier, the ability to tailor treatments, not only for recurrent disease, but for newly diagnosed disease is important. In terms of the surgical management of clavicle chordomas, we're seeing so much evolution with regards to surgery. In terms of, chordomas that initially we thought were not amenable to a radical resection with minimal morbidity, we're now able to improve those surgical results in terms of our ability to remove tumor and, leave patients with very little residual effects. And outside of sort of the overall management, I think the other area that I'm optimistic about is sort of the increasing recognition of quality of life. There's no doubt that some of the treatments that we offer can leave patients with some negative side effects. And I think we're becoming smarter about survivorship programs and improving those quality of life aspects once patients have completed their first line therapy. And I think that's equally important in terms of how we manage this disease process.
Great. That's awesome. Thank you so much for those thoughtful answers. Perhaps Dr. Raza, while you're on screen here, there's a question related to that, to those comments from a survivor is why, in spite of repeated treatments, do clavicle chordoma tumors grow back? One of the great frustrations, of course, is people endure long and arduous surgery, often have what looks to be a complete resection even, and yet the clavicle chordoma grows back again. And Dr. Gandhi, you could weigh in on that too, I would think.
Yeah, absolutely. I think in terms of surgery for clavicle chordomas, I think unfortunately there's some very unique sort of anatomic obstacles. If you look, the clivus is sort of the first floor of the house that the brain sits on. And what's challenging about surgery in this area is that on both sides of the clivus, you have the carotid arteries, you have multiple cranial nerves. It really is deep-seated at the base of the brain. And there are issues of how to get to the clivus. And in terms of surgery, how do you remove an entire chordoma with wide margins? And then how do you close everything at the end in a way that patients can go on to radiation therapy safely? And to my comment earlier, I think 10, 15 years ago, it was not that common that patients would get a radical resection or a complete resection. And then we saw the introduction of new surgical techniques that certainly have improved those outcomes. And I think now we're getting smarter in terms of using the full spectrum of surgical techniques to improve those outcomes. So, you know, it relates to the carotid artery, the nerves, and the deep-seated locations, which is why the surgical outcomes in the clivus, I think, haven't been as good in comparison to sort of the spinal chordoma outcomes.
So I would add to Dr. Rosa's excellent points. The anatomic structures that are limiting for what he can do in resecting these tumors are different than what is limiting for what we can do in terms of dose escalating radiotherapy to the clivus. A couple of basic principles is to recognize that much of the tumor that is in existence in the clivus cannot be visualized on an MRI. That these are microscopically infiltrative tumors, and we have to respect that. And I think to Dr. Nielsen's point, that experience really plays a role. In addition, it becomes important to recognize and work in close collaboration with surgical experts to understand how they resected it and the potential that walls of the area where the resection happened could have seeded cells. This is a very unique tumor, very dissimilar to other types of cancers that we manage in the body and some of those principles. And then I mentioned earlier the high-priced real estate. There are a number of important structures around the clivus, the brainstem, the optic nerves and chiasm, and the temporal lobes, just to name a few, that are sensitive to radiation. So it becomes a challenge to try to escalate the radiotherapy dose in the area where we need to try to cover as much as we can because of the potential for areas of microscopic cells. And all doing it while trying to keep in mind that if we do this right, patients can live a long time, and the effects of radiotherapy can manifest years down the road. And it relates to our ability to stay below the radiation tolerances of some of those structures. So you tend to walk a fine line in radiotherapy in terms of trying to treat these patients. But I cannot emphasize Dr. Nielsen's point anymore, other than to say it is crucially important that that first time is the best time. We've all treated patients who have recurrent chordomas, and those are challenging situations. They've already been treated with radiotherapy. How do you work around that? They've already had multiple surgeries. How do you work around that? When we have a relatively naive situation, that's our time to walk that fine line as best we can.
Thank you, Dr. Gandhi. Related to that question, it's a good question. Given the fact that as you put it, we're placing radiation around a high-priced real estate, much of it proton beam based, of course. Is there any promising research pertaining to regeneration of nerves that ultimately are affected by radiation?
Yeah, no, that's a really good question. I appreciate the individual who submitted that. Unfortunately, at this point, the capacity to regenerate nerves, like we see in a stroke, for instance, is very different than the capacity in the biology as it relates to repairing radiation injury to these nerves. Radiation injury is a process of inflammation, and it's a process of vascular effects that were exceeded in terms of the dose that those structures could receive. So we have some strategies. In my experience, the most important thing is to identify radiation injury early, act early before it kind of gets out of control. Commonly, we use steroids and Avastin. Sometimes we think about vitamin E and pentoxifylline, and I don't find it works very effectively, but sometimes we think about hyperbaric oxygen. But the most important thing is to prevent it. And to do that as safely as possible. And so it's a challenging situation, and we continue to try to evolve our technologies to try to focus on prevention as well.
Thank you. Next question, perhaps to Dr. Schwab. If there are clear margins on removal of sacral chordoma, what is the recurrence rate? And perhaps Dr. Nielsen, given your expertise as a pathologist, you could speak to this as well.
I think the difficult part here relates to the unseen aspect of chordoma, and this has been borne out particularly in sacral tumors. And so what we see on the MRI and what we can see oftentimes with after resection, we may have a clear margin or a negative margin. But it's been shown that there are microscopic foci of disease outside of that main mass that you can't see on the MRI, and so you don't know particularly where they are. And so if you have a negative margin, that historically has been the gold standard. But there's more and more data coming out that over time, the recurrence rate or these tumors do tend to recur. There was a study out of the Rizzoli Institute where they looked at patients who'd had a negative margin. And after 5 years, their local control was quite good. But after 10 years, the local failure rate was approaching 50%. And that's with negative margins. And that I believe speaks to the idea that there are microscopic foci of disease outside the mass. This was again borne out by a nice study from Japan, published a couple of years ago, where they specifically looked outside the main mass. Did they find any other sites of disease? And I believe it was over 40%, just over 40% of the cases they found areas of disease outside the main tumor. And so if there are cases where you get a negative margin, but there's still tumor left behind microscopically, it takes a long time for that to grow and you get these recurrences. So, negative margins are part of it, but as I said earlier, I think it's really a multimodal problem. And this is where we work with our colleagues in medical oncology and particularly radiation oncology to help with these areas outside the main mass.
I mean, theoretically, if you have negative margins and no tumor left behind, there shouldn't be any local recurrence. But I know people talk about these small microscopic foci. I don't, Joe can comment on that. I don't think that's been our experience, that we identify, and we examine these very carefully when we look at these specimens. Another thing that is also important I mean, we usually work with Schwab or the surgeon when they're doing these resections. So they usually bring the specimen to us and we look at it and evaluate it, and we see any worrisome features or positive margins, then Dr. Schwab can go back and take more from that area to make sure that the margins are negative. But he's right that people have reported some microscopic deposits outside the main tumor mass that you might not be able to see, could be very small grossly or by imaging, and that's the most likely reason why you get local recurrence.
If I could just make one more point, we do have a bit of a bias at our center because we do combine our treatments with most commonly with preoperative radiation therapy, and that is a possible explanation why we don't see some of these very small foci of disease. I can't explain it otherwise.
I could add to that, Ed, real quick. What we learn from the surgical experience informs the radiotherapy experience. Because sometimes, first of all, we treat these patients who are not candidates for surgery with radiotherapy. But it speaks to the importance, again, as Dr. Schwab mentioned, of not just treating what we see on a CT or MRI, but treating more broadly, more generously, the possibility that there are microscopic cells. And generally, it's in the gluteus maximus on sacral tumors, and that can be safely treated. So that should not limit our capacity to try to do that. And then as it relates to radiotherapy, Dr. Schwab brings up some really important points. There's a lot of controversies whether to do preoperative therapy or postoperative therapy. And I won't share my inclination on it too much, but it is hard to treat these in the postoperative setting. We're just guessing at the end of the day. So in general, my inclination, it's just my personal inclination, although I know other experts and colleagues of mine may disagree, is if it's in a postoperative setting, I typically don't treat. I watch and follow for patterns of recurrence. Whereas in the preoperative setting, we can potentially have an opportunity to see what we want to treat.
Excellent, thank you. Question, I think directed best to Dr. Cote. For recurrent chordoma, the question speaks to skull-based chordoma, for recurrent skull-based chordoma, but I think it can be generalized to recurrent chordoma in general. How do we choose which adjuvant therapy, so which additional therapy outside of surgery or radiation? How do we choose which treatment or which clinical trial is the best one in the case of that sort of scenario?
Yeah, again, I know this was mentioned earlier, but I can't emphasize enough how important it is to have a multidisciplinary approach to a given situation for for each of you each of the patients being evaluated. You know, every scenario is different. Every patient's different. The pace of growth can be very different between different patients. So there are situations where there might be a localized recurrence, and it's a single area that's growing slowly, and then nowhere else in the body there is a recurrence. That might be a situation where I ask my radiation and surgery colleagues, you know, can we just target this one area with radiation and surgery, or one or the other? That's a very different scenario than if it's spread throughout the body. Again, speaking to the differences between patients, I have people that I follow who've had recurrences, and they grow by millimeters every 6 to 12 months. They don't really need therapy right now. I mean, they have chordoma, it's growing, but it's not causing a problem. We just watch it, and we're kind of ready, waiting for that time where we need something. Whereas other patients can really have a lot of growth really quickly. And those are the people that need treatment right away. And then to help decide which therapy, that's an individualized decision. We need to look at what clinical trials are available. Where's the patient located geographically? Is it feasible to travel to participate in a trial? Has there been any genetic testing that might guide us on picking a therapy? All those factors play into the decision on which therapy to choose. So I think the best advice I can give is that you need to connect with an expert team, have them really carefully look at the situation, and help guide you to make a decision.
Thank you. Related to that, it's very easy these days to, everyone can be a Dr. Google in their spare time. Dr. Googles are everywhere. And so one of the things that people come across often is both solicited and unsolicited advice from others in their circle and via the internet. And so one of the questions that arises from that was submitted by a patient. Is there any evidence that a ketogenic diet or hyperbaric oxygen therapy, pulse electromagnetic field therapy, therapies like that are so-called alternative therapies could help manage chordoma?
Yeah, we don't know the answer to that yet. I find the ketogenic question interesting. There's a really good lab and experimental data in animals and petri dishes that this can work, but we've never really proven it in a human. It's really difficult to do those kinds of experiments. People have tried. It's just hard because we're very we're complex, right? Who's going to adhere to the right diet? How are we going to follow it? What's the right patient? What's the right study? So I think the jury's still out on that one. I've certainly had a few patients try it. It's challenging. You need to be really careful about your calorie intake and not getting too ketogenic, too ketotic, because that can be a dangerous medical situation. So, for me, for my patients, I generally recommend just a healthy kind of Mediterranean-based diet, and just trying to be as fit as you can be for any of these therapies that we offer, because they do have side effects. We want you to be strong going into them. If somebody wants to try ketogenic, I'm not opposed to it. I just don't have any evidence that it helps.
Are there any, just for the panel, are there any of these therapies, alternative therapies, that's from either a medical or radiation oncology or surgical standpoint that people should generally steer clear of, stay away from?
I'll speak from a radiotherapy perspective. Radiotherapy is a 8-9 week process. And there's so much we're doing at that time, so much we're delivering, so much we're trying to walk a fine line, that my general bias with alternative therapies is, if we can, let's hold off on doing anything during radiotherapy unless we know it's safe and potentially effective. After the fact, I agree with Dr. Coate. Patients can feel free to try alternative diets. Hyperbaric oxygen has never been clearly demonstrated to enhance radiotherapy effectiveness. There was some initial biology around it, not necessarily in the chordoma literature, but in the radiation biology world, but it never really panned out at a number of different malignancies. So I typically suggest steering away from that, both during and after the fact. But those are just my biases on that.
Yeah, I might add that for patients who are on systemic treatments, you just need to be really careful about different supplements and that could interact with any medications you might already be getting. They can affect the liver, they can affect the kidneys. There can be drug-drug interactions, so that it really needs to be carefully discussed with your oncologist.
Great, thank you. Just to circle back for a second to a more traditional therapy, specifically around proton beam radiation. Is it possible, Dr. Gandhi, is it possible to have proton radiation a second time on the same area? Can that be done safely?
Yeah, that's a really good question. Appreciate, again, the individual who submitted it. Reirradiation in general, we see a lot of it. We see a lot of requests and cases, consults. It's really challenging. There's no one answer fits all. Have I done it? Yes, I have done it in some patients, carefully counseled. But it requires a very detailed, as with anything, even in a surgical re-excision situation, a very detailed understanding of the biology of the tumor, what areas have been touched by radiation previously, what's the timeline since that prior radiation. There's some, what we call radiobiologic forgiveness of some of these tissues. And then what is the capacity that we have with our technology to safely treat? Now, we can always treat, but if we're not doing it to a substantial radiotherapy dose where it's going to offer any benefit, then are we really offering anything good there and just exposing harm? So I always tell my patients, radiation a second time is always an option. Generally, though, we have to be very careful. And in my experience, to Dr. Coates' suggestion earlier, the first time I typically treat more broadly, more generally, to treat areas that we cannot see, the tumor that is unseen, like Dr. Schwab said. And then in recurrences, sometimes more focally irradiate with technologies like radiosurgery, because those are the clonogens that have developed and grown, and perhaps that can be effective and safe. But all options are on the table.
Thank you. Perhaps Dr. Raza, you could weigh in on this too, because there's another question related to that individual whose parent had a skull-based chordoma 9 years ago, had initial resection endonasally, and then had radiation a couple of years later, and the tumor is now back, 9 years on. And the question is, chemotherapy, more surgery, what are her options?
Happy to take that. That's a great question. Unlike with newly diagnosed skull-based chordoma, where the treatment path is relatively clear in terms of surgery with radiation therapy, with the management of recurrent chordoma, the skull base, I think the decision is much more nuanced. And I get this question a lot. Generally speaking, when someone has failed proton therapy, we're not inclined to do repeat surgery. There are certain situations where we do repeat surgery, but when we've looked at our own experience, we tend to rely typically on repeat radiation therapy with stereotactic radiosurgery to treat those local recurrences. In terms of the role of surgery in that setting, as Dr. Gandhi had pointed out earlier, the concerns with doing repeat radiation is really the risk of radiation toxicity to the surrounding brain. And in situations where we're worried about the location of the recurrence relative to the brainstem, and we're worried about doing repeat radiation therapy, those are the situations where we do offer repeat surgery to clear that tumor away, to really make things easier for our radiation oncology colleagues. Now, certainly the landscape of managing recurrent chordoma has changed a lot because now there's an increasing slate of clinical trials. And so I think certainly 10 years ago, for someone with recurrent chordoma in the skull base, is either repeat surgery or repeat radiation therapy. And now, much earlier on, we're getting our medical oncology colleagues involved in looking at clinical trial options as opposed to waiting to the third or fourth or fifth recurrence.
Great, thank you. Thank you so much. I'm just going to, this question is submitted just live today, but also echoed by some of the questions submitted prior to today. But captured well by this question: is there a general time frame, if you haven't had regrowth in the X number of years, that you're probably safe in that you can be confident that it's not going to grow back, and you haven't guaranteed anything 100%? Maybe Dr. Cote, you can start with that.
Yeah, I think in general, most of these recurrences are early, but by early I mean within the first 5 years. But as you heard from Dr. Schwab, and there can be some slow-growing tumors that can recur late. So our general practice is to keep following people indefinitely, particularly for patients who receive a high dose of radiation. And Dr. Gandhi can comment on this, but there is a risk of secondary problems from that radiation. So we still follow people beyond 10 years for even for complications of the treatment.
Yeah, I would add to Dr. Cote's remarks, it's great when patients are able to live that long without recurrence, but to what Dr. Raza mentioned, then we talk about not just following the tumor, but survivorship issues. Survivorship issues related to what I'd have done on those patients, radiotherapy. So it's really important. I see it as a lifelong process and a lifelong relationship that those patients continue to be followed.
Absolutely, thank you. The flip side to that is, when patients are long-term survivors, for example, questions submitted by someone who is a 17-year survivor but is dealing with advanced metastases and so on, and has tried several medications, clinical trials, as we all can understand, frustration sets in, and sometimes hopelessness and a bit of despair. Very difficult for patients to know when they should stop, and when is enough enough. How should patients, what are the metrics by which patients should decide that things have become futile and they should focus on quality of life for their remaining time? It's a hard question to answer, I realize, but it's also a very, very real question for chordoma survivors. I don't want to pick on you all the time, Dr. Cote.
Yeah, sure. Yeah. So again, these are very individualized kind of decisions to make, and every situation is unique. So as I mentioned earlier, and I'm sure many of you noticed that there are certainly chordoma that grow slowly and can take years to cause trouble, and others that grow very quickly. One advantage to a disease that grows slowly is that you have the opportunity to take a break if you need it, if the thing's symptomatic, but also the opportunity to participate in a number of different treatments, because there's really no way for us right now to predict which of those is going to be the winner. So as long as you are fit, and by fit, I mean still, relatively healthy and not having major problems that would make you ineligible for a clinical trial, and there's a trial that's worthwhile, worth your time and effort, and maybe has good rationale, it's reasonable to think about that, as long as the sort of benefit risk ratios are enough that you'd be willing to take that chance. So for that right situation, I'd say it's worth keeping going, because we just don't know which of these is going to be the winner for you or for everybody else. But at the same time, somebody who's been through as much as you've been through, and it's exhausting, there certainly is a point where you might say, for me personally, enough is enough. I'm going to focus on the quality of the time I have left. And in that scenario, you would work with your team on focusing more on symptoms to kind of maximize the quality of the time left. Those are really individual decisions that you need to make, with your oncologist. But I fully appreciate the question. It's a scenario we run into all the time.
But I had a few more comments to Dr. Cote. Such a rare tumor. There's very few physicians across the country that manage a lot of these. I think if a patient has done their due diligence in trying to seek consultations and learn about options, I think everybody on this panel and everybody in the community who've managed these, we're pretty upfront and honest with our patients when that time comes. And as Dr. Cote mentioned, we've seen that. So if it's important to get that input and then make a decision from that point.
If I could just make a comment, I think that the same, it's obviously a different scenario to a certain degree, but the concept of taking into account quality of life and the impact the treatments have on quality of life is important, even from the index treatment, from the index tumor. And I think that is a bit, it seems now obvious that that's the case, but it wasn't that long ago where you had a tumor and you had surgery, and the fallout from that was felt for the rest of the life for the patient, but there was never really a discussion about quality of life and the impact of in that case surgery, but there are other treatments, of course. The impact on the patient's quality of life can be dramatic, and so I think the struggles that the patient with that question is expressing are shared by patients who have the primary tumor treated as well.
Absolutely. Thank you so much. Perhaps Dr. Schwab, I'm not sure if you've run across this. Chordoma itself is, exceedingly rare. Even more rare is familial chordoma. A question was submitted by someone who has a sacral chordoma. Sister also has sacral chordoma. And the question is, what screening in those sorts of scenarios should their children have, and who would order that for them if such screening was indicated? I'm not sure if you can speak to that or anyone else on the panel.
I mean, I think probably there are others on the panel that can speak to this more readily than I can, but certainly I would involve a geneticist. I think familial chordoma tend to occur more often commonly in children as well. So I think getting a pediatric oncologist and geneticist involved would be very important.
Yeah, I would agree. That's a exceptionally rare situation, and I think it really takes bringing in some expertise on this and to do the right testing to find why this is occurring within a family. So the National Cancer Institute has a pediatric branch that is interested in chordoma, and there is a genetic counselor there who is interested. The foundation navigators can certainly connect anybody with a familial situation like this, and I think that's a extremely high priority. So I would make sure that connection gets made.
Great, thank you. There's an issue, certainly as patients begin to live longer through advances in medical care and surgical techniques and so on, there's more and more patients who are discovering that they have nodules in their lungs. This has come up at previous Ask the Experts panels as well. Question is what to do about them. And obviously it causes alarm for patients who discover that they have spots in their lungs now. It spells, the ugly word metastasis. And all of the negative connotations that come along with that. So with respect to spots on the lungs, is there, first of all, should they be surgically removed? I'll ask the surgeons on the panel. And if not, are there medical options here, or is it simply monitoring? Should it be irradiated? So I think all of you can speak to this, including you, Dr. Nielsen. If you've seen some of these specimens that have been removed pathologically, what do they look like? Do they resemble the native chordoma tumor when you examine them under the microscope? Maybe start with you, Greg, since you're Dr. Cote, since you're on my screen.
Yeah, sure. So this is a difficult situation. So first, if we scan any of us, you're going to find little lung nodules. Our scanners are sensitive enough that we often are going to pick up something and every time somebody's scanned. And the question is that chordoma or not? The imaging features and the number can kind of help us guess whether these are real or not. And in general, most of us are going to follow these over time. And if they're growing, then that would be consistent with chordoma. In the majority of patients, there are many small spots, and going after an individual 1 or 2 or 10, I haven't seen benefit with that in most patients. There are individual situations where we do go after them, but in general, we're not targeting them with surgery or radiation, more with medical therapies if they're progressing. If there is one spot that is outgrowing the rest or is causing symptoms, that would be a reason to consider surgery or radiation for that.
And histologically, for the vast majority of cases, they look like the conventional chordomas that were. I most frequently sacral chordomas that metastasize, but all chordomas can, and they look like the primary tumor. So it's pretty straightforward diagnosis to make.
I think the other thing to keep in mind, I think Greg mentioned this as well, many times we have patients who have nodules that we believe are chordoma. They've grown very slowly, but they continue to grow very slowly. Not in all cases. I mean, there's certainly in some cases an acceleration, but we have many patients who years and years go by and they may or may not have had any systemic treatment, and the tumors seem to go particularly slowly. and we don't have a great explanation for it. I mean, and that's not to say you shouldn't have it checked, because there are some exceptions to that. But I think it's safe to say there's a lot we don't understand about these tumors, and when you have metastatic tumors, perhaps we understand even less.
But to make a point, what Joe was saying is that also for Greg Cody is that makes evaluating treatment sometimes difficult, because you can see chordomas that are not being treated, that don't progress or have very, very little progression for a long time, and then without any treatment. So when you treat them and they don't change, is that because the biology of the tumor? Is that because the treatment is effective? I think that's a problem with many of these chordoma patients.
Yeah, I would agree. So that's why gets to that point I was mentioning earlier, that the timing and choice of which therapy to give is dependent on those features for any given patient. So if they are not growing or not growing quickly and not causing symptoms, you have an opportunity to potentially just watch things. If it's growing quickly and causing symptoms, or things are starting to get out of control, then that's certainly a trigger to start a systemic treatment in my mind.
I'm going to add some comments also. I mean, certainly the question primarily focused on pulmonary nodules, but we also do have patients that can have metastases to the spinal column, and there are also the issues of not only concerns regarding imaging, but also back pain and sort of issues related to the spinal column. And certainly, whenever there's metastatic spread, we always want to evaluate systemic therapy. But in our practice, also, whenever we see metastases to the spinal column, that's where there's also a good role for sort of focal radiation therapy to help with a lot of the symptom control and quality of life issues too. So that also is an important part of the treatment paradigm at that point.
Yeah, I'll add to Dr. Raza's comments from a radiotherapy perspective. Again, radiotherapy is a local therapy, and unlike surgery, it does not provide tissue sampling for next-gen sequencing, or maybe something that might be informative of systemic therapy. So to some extent, with radiotherapy, we are very selective in the metastatic setting. We need to Dr. Schwab's point, we need a biology to show something's growing. Number two, we need to make sure that that it shouldn't be better to just take it out and understand it under a microscope and through genomic sequencing. Number three, is this going to cause an issue? Lung lesions typically don't cause issues. Spinal column lesions, they do. And number four, is everything growing, or is just one thing growing? Because it is only a local therapy. So those are the questions that we think about.
Thank you so much. I would add on a personal note, as a clavicle chordoma survivor myself, I had pulmonary nodules detected, I think, 7 or 8 years ago, about 13 and a half years into my own journey with this thing. And so we've simply been watching them, and they sit there and they grow microscopically very, very slowly. And I think that's based on my conversations with other patients over the years, that experience is shared by others as well. I have a question. There's a lot of buzz in the chordoma community about a particular drug called afatinib. And again, on a personal note, I take afatinib myself. So the question, there's a couple of questions around this. First of all, are there any early results to report from the afatinib trials that are ongoing? And is the thinking that it's likely going to be one of these drugs that can be useful as a long-term maintenance drug? I suppose similar to what Gleevec does for patients with a certain type of leukemia. What do we know about afatinib so far? Is there any updates that can be provided? Perhaps Dr. Cote?
Yeah. So unfortunately, we do not have any early results yet from that study, but I think we're all eagerly awaiting it. It's very hard in the U.S. to get that drug approved, and I think if we had any clinical trial evidence that it's working, that will make it available at least off-label for us to prescribe. But I personally had very little luck getting access to it for patients. So we'll see. There's some really interesting mechanism of action work that was presented at the meeting, and that it's still preliminary, so I won't go into the details yet. But it may be more than just attacking the EGFR receptor, which is a protein that drug is designed to target in lung cancer. It may go beyond that to sort of how different genes are turned on and off. And I found that to be quite exciting, and I really hope this study is positive. We're really looking forward to seeing the results when it's back. But at the moment, we just don't know. That's why the study's being done.
We don't know, and it's hard to get access to the drug, as you said.
Correct.
People.
Exactly. Yeah. You know, as to the maintenance question, I mean, that would be amazing if that holds true. But we won't know that until we get the study results.
Do you know? Could you just let people know if people do end up availing themselves successfully of that therapy? What are the limitations as far as side effects?
Yeah. So a lot of these medications can, cause some GI side effects. They can cause rash. There can be some effects of inflammation in the lungs. You know, things that we really learn from patients with lung cancer who have been on these drugs. But you know, it's approved, and as you know, people can take it long term, and you know, I think with the right supportive care and dose adjustments, it can be given for a long time.
Awesome, thank you. A question for Dr. Gandhi. Do you think the opportunity to use drugs to sensitize tumors to radiation therapy can be helpful with metastasized tumors or with a primary tumor? What's the current thinking around that?
Yeah, another really good question. Let me first speak about the primary tumor. Again, we're trying to walk that fine line. So we are actively trying to identify drug therapies that might enhance radiation's effectiveness, but at the same time not enhance radiation complications, because that can also happen. And I think that the most important is to be able to test it in clinical trials. So there are a couple of agents that we've been looking at to do that. In the setting of the metastatic situation, again, but radiotherapy is a local therapy. So enhancing radiation's effect on a local area in a widely metastatic situation may not be all that useful. But in scenarios where we might be able to amplify the systemic response to metastatic disease is a hypothesis that I think we're still testing. And commonly the most classic example is immunotherapy. Immunotherapy in melanoma, which has shown remarkable results, non-small cell lung cancer, has also shown that radiotherapy, of several lines of evidence that radiotherapy amplifies immunotherapy's effects systemically. I think that question remains under investigation in the setting of Chordoma, but certainly worth looking into.
Great, thank you so much. Question for Dr. Schwab. What do you think of intracapsular debulking for sacral tumors? The comment made by this questioner is that it seems to carry minimal risk and have good palliative benefits.
I think from a palliative perspective, if you're having lots of symptoms, I'm certain it can palliate symptoms, decompressive operation. I worry about the long-term effects of intracapsular treatment without an effective adjuvant. So I know that at Memorial Sloan Kettering, they are using a form of intracapsular resection, so-called separation surgery, in combination with hypofractionated radiation therapy, and they have good short-term results are good. I think intracapsular treatment in the spine and sacrum, though, historically have not done well without an adjuvant. Data from Sweden, for instance, demonstrated 53 patients, 52 of them recurred with that form of treatment. So I think that may be the future. I don't think that is an effective way of treating primary tumors as a standalone. You really have to have an effective adjuvant in that setting.
Great, thank you. Dr. Gandhi, related to that, if people choose not to have surgery for a sacral chordoma and choose instead only to attack their disease with radiation alone, proton beam radiation alone, for example, are their outcomes expected to be any different from those people who choose to have surgery and surgery plus radiation?
Yes, another excellent question and a point of controversy is enough so that there's a trial being run exactly on this topic. My general inclination is to typically consider surgery, but in many of these patients, especially older ones, or where there's nerve compromise or potential for nerve compromise that may affect bowel or bladder function, many of the surgeons we collaborate with indicate that surgery would be associated with too many complications, in which case radiotherapy can offer an effective treatment, specifically with protons, to try to escalate radiotherapy dose. What we don't know, though, with radiotherapy is the capacity to control that tumor for a long period of time. Many of the results we have a median follow-up of maybe 5, at most 10 years. So when we're talking about a younger patient, pediatric as an example, or someone in their 20s and 30s, we anticipate to live decades. I think I'm hard pressed to say radiotherapy is equivalent in that situation when thinking about them over their lifespan. And in that case, I think our general bias or inclination is to be more aggressive with multimodality therapy.
Great, thank you. Dr. Raza, question that comes up from time to time for clavicle chordoma patients postoperatively with regard to things that they should avoid after treatment, after having had surgery and radiation. Particularly, I think this question pertains to surgery. Should clavicle patients avoid lowering their head after treatment? Is it dangerous to engage in activities like yoga and so on with your head on the ground? This question has come up in recent years around flying and these sorts of things. Comments around that?
It's a great question. You know, a lot of those concerns regarding position restrictions after surgery for clavicle chordoma relate to the fact that, you know, if the dura or the envelope around the brain has to be opened in order to remove the tumor, you know, of course, we spend a lot of time during surgery reconstructing and closing that dura. And certainly it usually takes about 4 to 6 weeks after surgery for that reconstruction or for that closure to sort of solidify. And so a lot of the position restrictions are really during that initial 6-week period to prevent a postoperative CSF leak and allow for that closure to heal. In my own practice, after that 6-week period is up and after we verify that the reconstruction is healed completely, I ease off on all the position restrictions for my patients, meaning that they're totally fine to do whatever they want to do. If they want to fly, they can fly. And that once you're out after surgery and after radiation therapy that far out, those position restrictions go away.
Great, thank you. Another question for the surgeons on the panel here, but really I think each of you could probably speak to this. One of the great frustrations around diagnosis and treatment is that if you are not in a center that is a center of chordoma excellence, and you wander into a doctor's office with this diagnosis, and it is still too often the case that the initial treatment that's offered and applied is incorrect. And so the question is, what efforts are being made to educate neurosurgical centers throughout the United States and around the world what to look for on scans that reveal chordoma, the appearance of a chordoma, so that centers with lack of experience, basically just to paraphrase here, don't muddle around in areas where they shouldn't be muddling.
Sure, I can take that question. I think there's several ways that we're tackling that. I think generally within neurosurgery, we've gone towards increasing subspecialization. So, you know, even though neurosurgery is already very subspecialized, dealing with brain and spine surgery, I think there's definitely a recognition, even within large academic centers like at MD Anderson, that the clavicle chordomas and the spine chordomas end up with the spinal oncologist and the skull-based oncologist, and that the other neurosurgeons tend not to touch them. So education and the importance of subspecialization is one aspect of it. Another aspect of it, unfortunately, that's out of our control, is really access to care and insurance, right? And that's sort of, I think, a larger battle that we'll have to sort of tackle, is that really restricts patients' access to centers of expertise.
I think one of the other issues that is helpful, and we went through this in orthopedic oncology, was the value of obtaining a well-placed and well-thought-out biopsy. And that's also a controversial area, but making the diagnosis before surgery is performed is crucial, because you know, if you go and operate on someone thinking it's a certain tumor, and then come to find out it's a chordoma, which you find out a couple of weeks later, that really is a problem. So even in someone who might know that should be referred, if they don't have a biopsy up front, they won't know to do that. So I think getting a biopsy and educating that's something we talk about in our national meetings, which are attended both by orthopedists and neurosurgeons in this area.
And if I can address some thoughts from a radiotherapy perspective. You know, it was not too long ago there were only 2 proton centers in the entire country, or 3 with Houston joining the board, and now there are almost 30 proton centers, which is great. That means we brought a technology that really helps chordoma patients to vast areas of the country that never had that access before. But just because you have a proton center doesn't necessarily mean you have the experience or expertise to manage a chordoma. We within radiotherapy and leadership have recognized that many proton centers are specialists are treating chordomas and have never treated one before, so they're learning as they go. So we're trying to develop with the Chordoma Foundation leadership a registry where we collate all our outcomes and we can all learn from our outcomes, and we can create guidelines that we can educate. It's not uncommon that I get phone calls from radiation oncologists at other proton centers saying, hey, can you help me out in this case? How would you approach it? And I'm more than willing to help them and guide them through that process. But to some extent, 8 or 9 weeks away from home, away from family, it's a big ask. And I definitely appreciate that. And so we in radiation oncology are trying our best to bring the expertise and the technology to patients as best we can.
As far as the biopsy question, this comes up routinely as well. A lot of confusion on the part of patients. I see it on the, there's a Facebook group, a Chordoma survivors group. Question crops up repeatedly. Should biopsies be done? And if they are to be done, how should they be done? Should they be done in a particular way, or should people just initially have the initial, invasion of the tumor to be the attempt at surgical resection? Dr. Raza?
Sure. Certainly within the Clivus, and the first issue really this highlights is the importance of good imaging. As opposed to some of the other types of tumors and cancers that we can see within the Clivus, if you have a good MRI scan that's really focused on the skull base, chordoma tends to have a characteristic appearance relative to some of the other growths that we see in this area, and so that really has reduced the need for a biopsy. Now, even in a center of ours, every once in a while we'll see a growth that may be a chordoma and maybe something else, and in those cases, what we do plan on doing is, if we're going to do a biopsy, we'll go to surgery with the intent of removing the tumor, but since we have great pathologists there with us during surgery, we get that initial sample. We know very early on if this is chordoma or not, and if it's not a chordoma and it's something else that should be treated with something aside from surgery, essentially it's just a biopsy where we haven't caused any harm. If it is a chordoma that we determine during surgery, then essentially we go ahead with the rest of the surgery and remove everything. So generally, I'm not a big fan of doing purely a biopsy, but if one's needed, it just needs to be planned by a surgeon that's going to do the removal at some point.
I would say that it's another illustration of the complex field of chordoma, in the sense that there's really differing views, and for good reason, right? I don't treat clival chordomas, and I do treat chordomas in the rest of the axial skeleton, and I don't know that there are cases where we've gone to surgery without a biopsy. Just illustrates the differences, so I think in that setting, we typically do have obtain a biopsy, but I agree with you. If you're going to do that, it needs to be in conjunction with speaking to usually our radiologists do these biopsies, but typically they'll do that in collaboration with us in terms of planning the biopsy.
For sure, thank you. The question arises around this issue from patients on occasion: is the biopsy necessarily going to lead directly to a diagnosis? So Dr. Nielsen, like on pathology, is it sort of an on-off switch when you look histologically at a sample? It's pretty obvious that it's a chordoma, or is there some debate? Is the decision around whether this is a chordoma or not arrived at by a single pathologist? Is it a group decision? How is that diagnosis made?
Well, from my experience, we see so many chordomas that diagnosing chordoma is pretty straightforward histologically. I mean, we have in problematic cases, there are stains that you can use to confirm the diagnosis. And some of the question I noticed about brachyury, and brachyury is a specific marker for notochord and cells that show notochord differentiation. So in rare cases where there's a small biopsy, and as you might or might not know, there are like 4 different variants of chordoma. So in some of these other variants, you do need special stains for confirmation. But for the classic, most common conventional type of chordoma, it is usually a pretty straightforward diagnosis, just regular H&E stained class slide.
But Peter, straightforward for you. And I mean, what do you think about community oncologists or even centers that maybe don't see a ton of chordoma?
Well, yeah, that's what I said in the beginning. It's like, well, the problem is if you've never seen one before, then you might not know what it is, and that is a problem. And we've seen chordomas being misdiagnosed as metastatic carcinoma, like some other types of malignancies. And just because the reason being that it's a rare tumor and people don't see it, and some pathologists might never see an example of chordoma. So that is true that it can be problematic if you don't know what it looks like and you haven't seen a case before. So it happens.
Peter, what do you sorry, I don't mean to keep asking questions, but Peter, what do you think about other pathologists sending their potential samples to people like you for second opinions?
Well, I think they should, if is there any question about the diagnosis, because obviously the treatment is going to vary depending on what the tumor is. And I think that's something that I've seen through the Chordoma Foundation, or sometimes they recommend biopsy being sent to pathologists who are used to looking at chordomas just to confirm the diagnosis. And I think if there's any question about the diagnosis of chordoma, and if the pathologist is in any doubt, then obviously he should send it to a pathologist who's used to looking at chordomas, which are usually, you can find one in one of those centers that sees a lot of these chordomas.
This really relates to one of the biggest challenges faced by newly diagnosed chordoma patients is how to navigate all of this, because one of the questions submitted today by a chordoma survivor, how does a patient navigate different views and opinions from physicians and surgeons who are well-intentioned enough? Often you cannot know what you do not know, to trot out the old adage, you cannot know what you don't know. People are well-intentioned enough in their centers. Patients are confronted with what sounds to them an awful diagnosis, and it's very frightening. And the inclination on the part of patients often is, let's get going and find a solution as quickly as possible. And so the bias in centers that are not centers of chordoma excellence, unfortunately, sometimes can be to get to surgery and treatment. When patients reach out to the Chordoma Foundation and are told that they need to go to a center of excellence and they need to get a second opinion, there's a power differential between patients and their doctors. What are some suggestions with regard to how patients can navigate this sort of thing? What are the tools that they can use to go to their healthcare providers and say, well, with respect, this is what I'm being told by the Chordoma Foundation? Tips and tricks. Dr. Cote, maybe you could start.
Yeah, sure. So I think Peter said this in the beginning. It's so important to do the initial management, to approach the initial management correctly. And the disasters, situations that we see are when somebody gets in there and oops, they didn't realize what it was, and it's too late now. They've already gotten into the tumor, and that almost guarantees trouble down the road. So I think it's incredibly important just to pause, and then arrange for a second opinion. This can be done virtually now. I mean, that's one silver lining of the pandemic, is that the restrictions between interstate video consultations has been lifted. So we can see patients from around the world, which has been phenomenal. If your team starts getting offended that you're getting a second opinion from a site that takes care of chordoma, maybe that's the wrong team. Like I don't pretend to have all the answers. If one of my patients gets a second opinion from a colleague, great. I'm happy to get their opinion. I mean, it's not. I don't think there's room for a lot of egos here. I think we need to work together for this disease. It's so rare. There's so much nuance to the management. If somebody's being resistant to you getting a second opinion, maybe you need a different team.
Also, the point is that there's no rush. This is not a rapidly growing tumor you need to treat right away. So the patient just need to step back and take their time and find the right place where they should be treated, or at least get a second opinion from a place that knows what they're doing.
I'm going to highlight that point. Certainly, you know, within the skull base, a lot of patients tend to present with symptoms such as double vision, and that always adds some anxiety about rushing into treatment, surgery, and then sometimes getting rushed into radiation therapy. And it is so critical to take that time up front to get all the information and get the second opinions. There are very few circumstances in the skull base where surgery needs to be done as an emergency. And especially if you're getting rushed into radiation therapy before you get committed to that, I think that's also another time point where you really have to make sure that surgery has been maximized before you get put into radiation therapy. So those are the certain checkpoints to make sure that everything's being done accordingly.
I can add from the radiotherapy perspective, I agree with especially in the postoperative center, there is no rush. We should take our time to figure out what's the best thing to do. My general bias is radiation oncology is in part driven by experience and expertise, but it's also in part driven by technology. And to some extent, the radiation oncologists that provide the best care in this situation are the ones that have all the tools at their disposal. Oftentimes, some places, institutions, physicians will say, well, this is all I have, and I think I can do this, so let's do it. I think patients and family caregivers can take a moment to pause, use the Chordoma Foundation. I love the fact that when you go on Dr. Google and you type in Chordoma, the Chordoma Foundation is one of the top pages that come up. Use them to help educate and query one's own care team. How many tools do you have? What about this approach? What about that approach? Why would we not consider that? And I think those are important questions to ask and learn.
Great comments. Very helpful. Let me pivot for a second to the monitoring phase of this disease. I know we don't have a radiologist on our panel, so I'm not sure to whom to direct this question. It's a good question, though. Are there any disadvantages to having an annual MRI, even though scans have been clear for a prolonged period of time, for example, for 10 years or more? Is an annual MRI still indicated, and is it safe?
So I'll take that one since I'm a radiation oncologist, but I'm board certified by the American Board of Radiology.
Right.
MRIs are safe. It's not a CAT scan. Sometimes when you think about a CAT scan, you think about radiation exposure. But even an annual CT still stays way below acceptable limits for radiation exposure for any person, let alone a chordoma survivor. MRIs are magnets. They're not CTs, they're not X-rays. There's no radiation exposure. So MRIs are permitted. One of the things we are learning in radiology is the total amount of gadolinium exposure that patients have. But that is for patients who get, 4 or 5 MRIs with gadolinium. Gadolinium is the contrast agent. We get 4 or 5 MRIs with gadolinium in a year, that there's thoughts that maybe that there's too much gadolinium being exposed, especially to the kidneys, and has deposits. But that's not the case in a chordoma patient. So getting annual MRIs or twice annual MRIs with gadolinium is the right thing to do over the long term.
Excellent, thank you. Dr. Raz, a question here around damage to optic nerves with skull-based chordoma surgery, whether the damage to the optic nerves occurs from the surgery itself or from radiation treatments following it. I realize those are 2 separate questions, resulting in visual impairment. Is there mechanisms by which that can be salvaged or repaired?
Sure, so I'm gonna take a little poetic license to that question in terms of there are a few ways that skull-based surgery can certainly affect vision, unfortunately. Certainly the nerves responsible for vision themselves, and then the nerves responsible for eye movement can result in double vision as a result of surgery. When there's injury, either from the tumor or from surgery to those nerves responsible for eye movement, there are some pretty effective means to actually help repair those symptoms. And that's where the having a good ophthalmologist and good oculoplastic surgeon on board, not necessarily during surgery, but typically 6 months after surgery, we tend to see if there's going to be any recovery. And if there isn't, then there are some minor and simple things that can be done to help restore double vision or correct double vision, such as adjusting glasses or sort of shortening the muscles responsible for eye movement. Now, in terms of the nerve responsible for vision, the optic nerves, unfortunately, at this point, there isn't much that can be done to restore visual acuity in terms of how clearly one sees something. A lot of it is sort of just a wait and see to see if there's going to be any recovery after that initial injury. To the radiation question, I'll leave that to Dr. Gandhi in terms of your comments.
Yeah, no, and we talked about this earlier, but it really is an important question. So let me expound on what I said earlier. When we deliver radiotherapy and we plan radiotherapy, we kind of play what I like to call a game of playing the percentages. The higher the dose we escalate the area we need to treat, the higher the percentage we're able to control that tumor. But at the same time, the higher the dose we escalate some of these tissues, the higher the percentage risk of causing injury. This is different from surgery, as Dr. Rosa mentioned. If the nerves are touched and harmed in surgery, there's a near certain risk of causing injury. With radiotherapy, we expose the nerves to radiation all the time. But how high do we go, and what percentage risk do we accept in that situation? And so when I talked about prevention, I talked about using our technology to maximize that therapeutic window, increasing the likelihood and percentage of controlling tumor and decreasing, but not eliminating, the percentage or likelihood of causing some vision damage. Now, similar to what Dr. Raza mentioned, a number of different nerves impact vision. Certainly diplopia is caused by nerves that run through the cavernous sinus. They tend to be much more resistant to radiation, meaning if we escalate the radiation dose to those nerves, the percentage risk causing diplopia from radiation is very low. I would say less than 1 to 2%. The vision nerves, the optic nerves that actually provide vision, are much more sensitive to radiation. So if we escalate the radiation to that, the risk of causing what we call optic neuritis, or inflammation of the vision nerves in a way that actually causes vision loss, goes up. And once you hit a certain threshold, it starts going up in a sigmoidal exponential response. And so oftentimes when we plan radiotherapy, we balance those percentages. Oftentimes if I see tumor right next to one optic nerve, I tell the patient, look, I got to control this tumor, because if we don't, and it recurs in the future, and then it's going to cause vision loss. So I'm accepting a higher percentage risk of vision loss in that one eye, but I'm trying to maintain vision loss. trying to maintain vision in the other eye. So those are the conversations that we have with our patients and trying to optimize their outcomes.
And
yeah, go ahead. Sorry, Dr. Raza, go ahead.
Sorry, I was going to say that to Dr. Gandhi's point is that the optic nerves is one of those critical structures that limits his ability to deliver the right amount of radiation therapy. And that's why it's important to have a good relationship between the surgeon and the radiation oncologist, because there are times where we see patients where part of the tumor may have been removed, and then they come to our Proton Center for referral. And one of the most common reasons why our Proton therapists send me patients is because there'll be residual tumor against the optic nerves or residual tumor against the brainstem. And certainly as a surgeon, my primary goal is to remove everything. But the next best thing, at the very least, is I have to remove tumor away from those structures, such as the optic nerves, to really limit that long-term radiation risk that patients may suffer and really enhance their ability to sort of recover and have a good outcome from radiation therapy. So the optic nerve is definitely a key important structure to keep in mind.
Let me add something to Dr. Reza, because that's super important. It goes back to centers of excellence and people with experience. Is you want a radiation oncologist that's willing to pick up the phone and call a neurosurgeon who treated that patient and say, I think you need to take more out. And if that individual says no, then they're willing to pick up the phone and call Dr. Raza or whomever that they trust and say, I don't think this is right. I really think you should take more out. What do you think? And then they bring the patient in. It's trying to do what's best for the patient, and then that relationship is so vital.
There's a question here related to that, Dr. Gandhi. Is it imperative to travel to find proton beam therapy, for example? Is there any meaningful difference between traditional radiation versus proton radiation?
It's a really good question. So when we talk about traditional radiation, there's a lot of different forms of it. So traditional radiation, in my mind, is something that's based on X-rays. And X-rays have certain principles or properties that prevent us from walking that fine line. Now, there are some technologies with X-rays. Radiosurgery is an example that allows us to walk that fine line, but sometimes we are limited in radiosurgery by how much we can treat. we have to treat a smaller area because we're treating a much higher radiation dose in a single or maybe a couple treatments. In chordomas, as we talked about, it's about the tumor that's unseen as much as it is about the tumor that is seen. And in those scenarios, best at the first time to treat more broadly. So proton therapy offers that opportunity to walk that fine line as maximally safe as possible. To the question, this is an issue of access, and it's a challenge. But I do agree with everybody that it's worth having a conversation with the radiation oncologist that has all the tools in the toolbox and has the experience and expertise. And there's several of us all across the country, a lot of my friends and colleagues who do this, who can think about what is the best approach. And sometimes protons is not the best approach, and you have to think a little bit of other modalities. So it's very individualized, it's very personalized, but yes, compared to conventional, what we call IMRT, when treating a broad area, for instance, in the skull base around high-priced real estate, there are some clear advantages with protons.
And then, in recent years, comments or questions around this newer technology called pencil beam radiation. What is that?
So pencil beam radiation is, so when we deliver a proton beam, we typically we deliver a whole array of protons that go and stop. So if I took some protons and I shoot it into a bucket of water, I know at a certain energy it's going to stop at a certain place. So typically we do about 220 MeV protons, that's the energy, and it'll stop at 20 centimeters. I know that is the principle. So if I take a whole array of protons, all with the same energy, they're all going to stop at 20 centimeters. So then what we do, old school protons, uniform scanning, passive scatter, was then we put all these devices in the proton beam to try to get it to stop sooner or further than where 20 centimeters is. Pencil beam scanning is different in the sense that we can take each of the proton particles and modulate their energy such that they fall and end in different spots. So that allows us to shape the proton treatment to that tumor much more effectively. At the same time, another technology is using what we call apertures, which are big brass devices that we put into the sides of the beam, and then we cut the beam off at the edges on the sides. And that allows us to then skim off some of these important structures like the optic nerves or the brainstem. So a really significant advance in protons. And that is one of the things that radiotherapy is really exciting, is that there's a lot of continued advances in proton therapy that keeps happening every few years.
Great, that's exciting stuff. Thank you so much. A question for Dr. Cote. Very practical question. What lifestyle choices would doctors recommend to assist in controlling chordoma post-diagnosis, post-initial treatment, and so on?
Right. So this gets a little bit into what we were talking about before. In general, most of the kind of extra stuff we do outside of the medical treatments are not going to impact the chordoma itself too much. However, to be able to take any of the treatments, surgery, radiation, chemo, clinical trials, targeted therapies, we do want you to be as healthy as you can be. So probably not a good time to start smoking, not a good time to get into any kind of risky behaviors. We want you to try to be healthy, eat well, try to do some exercise as tolerated, and sort of be as strong as you can be to help fight this disease.
Great, thank you. One of our patients was told by one of her doctors, an infectious disease doctor, that history of cancer is a risk factor for severe COVID-19. So I thought we would wrap up our discussion with, since we're in this pandemic environment, with a pandemic-related question. How worried should our chordoma survivors be, in particular, with regard to COVID-19?
I'm not sure we know the answer to that specifically for chordoma. I mean, the clear risk factors are as you've seen in the news, are age, comorbidities like diabetes, obesity, reduced lung function. Those things matter for sure. A history of treated cancer and cured cancer probably is not a major driver. If somebody's on some kind of systemic treatment that might impact their immune system, that could hurt. At the same time, COVID's unique, where there's this kind of secondary phase of inflammation where people can get really sick if they get that. And in that scenario, a lot of the drugs that are being investigated are actually immune suppressive to try to damp down that immune response. So I think we just don't know at the moment. I think for the individual patient, if you're fit, you're younger, your organ function is good, you probably have to share the same risk as everybody else. If you have pulmonary lung compromise or kind of organ compromise from some of the treatments, then yeah, that might put you at risk. For COVID, I think the best treatment right now is prevention, and if you can avoid getting it, that's the best thing, because we just don't know who is going to get sick. I have colleagues who are physicians who got it and are fine and showed up to work and didn't realizing they have it, and others who got quite sick and were in the ICU. And there's, we don't know the difference between those people. They were a similar age and didn't have any other medical problems. So I think right now, until there's a vaccine, best to try to avoid it. Do what you can, wear a mask, social distance, be smart, and we'll get through this. It's just going to take some time.
I can add a point from a radiotherapy perspective, Ed, real quick. So I agree with Dr. Cote that from a radiotherapy perspective, radiotherapy does not increase the risk of causing symptoms from COVID-19, nor does it make it more likely to have severe symptoms. But when you come in for radiotherapy, you do come in on a daily basis into a healthcare setting for 8 to 9 weeks. And that exposure is very different for patients. Normally they're sitting at home, they're quarantining at home, they're being very careful. Now they're coming into a healthcare setting on a daily basis. I can tell you here, and I'm sure at every one of the institutions that are represented here, we are very careful. Here's my mask right here. Very careful about taking care of prevention for these patients when they come in. No visitors allowed. Only the patients themselves can walk in through our doors, as an example. But it's also recognition. I can tell you I had a couple Chordoma patients when things really kind of was out of control in March here in Chicago. To Dr. Nielsen's point, there's no rush. I told those patients, look, let's just wait. Let's let the case count come down. And when it's safe to do so, then we'll bring you down to Chicago and we'll start doing your treatment. And we were able to do so safely and effectively. So it's just an understanding of what that epidemiology looks like in different parts of our country. And to Dr. Cote's point, prevention.
Absolutely. Very, very helpful. I think, as a medical professional myself, the one thing that all of us have become quite good at with regard to this pandemic is saying, I don't know. There is so much, this is novel, this is new. Many of us had what we thought were informed opinions at the beginning, only to have those opinions upended by what the reality proved to be. So related to that, I suppose as a way to end our discussion today, this is how we began with chordoma. When I was diagnosed almost 13 and a half years ago, there was very little known about chordoma. We now know a lot more, and it's really thanks to the efforts of surgeons and physicians and pathologists, all the different medical professionals that have dedicated their careers and their time and their efforts and goodwill to helping us to understand this disease better. So I want to thank all of you for taking the time out of your busy schedules to lend your expertise to this really useful discussion for our Chordoma community today. I know there's a lot of questions on the board submitted prior and on the board today that we didn't get to. We will try to get answers to all of your questions through the Chordoma Foundation. I think the one message we hear over and over and over again is how critical it is to involve the Chordoma Foundation, its navigation service, and all of the expert panels that we list there, clinical trial registry, and so on. It's such a powerful tool for patients. And those of us who are involved with it, those of us who have used it, it's really incumbent upon us to spread the word to others who are similarly affected to make sure that they get the care that they need. So once again, gentlemen, thank you all for your time today. Absolutely awesome session once again.
Thank you.
Thank you.
Thank you, Ed. And before we sign off, I do have a couple comments. Let me share my screen. There we go. I want to mention the Chordoma Survivorship survey. This survey is now available on our website as part of our recently launched Survivorship initiative, which is focused on helping our community live well during and after treatment for chordoma. We heard a number of times from the doctors during the webinar today. Quality of life issues during and after treatment are very common and often have significant impacts on the overall well-being of both patients and their family members. So the goal of the Survivorship initiative is to provide information and resources to help you get the care and assistance you need to deal with any issues that might affect your quality of life. And in order to develop and provide these resources efficiently, we want to hear from everyone in the Chordoma community. So whether you're a patient, a survivor, caregiver, co-survivor, family member, we want to hear about your experiences. We've created a brief survey to make that possible, which is available on our website at chordoma.org/survey. And a link should be shared in the chat box right now as well. So if you haven't already taken the survey, please click that link to take a look. The survey takes only about 10 minutes, and we would so appreciate if you would take part in that. And finally, to our panelists and Ed, our moderator, thank you so much for being here with us today. This is a great opportunity for our community, and we thank you for making it possible. Thank you to all our attendees for joining and asking all these excellent questions. And please remember that if your question was not addressed, as Ed mentioned, we will be following up with you. And our patient navigator, Andrea Locke, is here to assist you anytime. You can get in touch with her at chordoma.org/request-help. And as always, feedback is welcome. You'll receive an evaluation form by email about this webinar, and you can also email us at support@chordoma.org. Thank you so much again, everyone, and take care.